Okay, ma'am, we are live. Okay, so good afternoon, everyone. Today we have a esteemed faculty, Dr. Nandita Palshetkar, with us. She is a professor in obstetrics and gynecology at Diva Patil Medical College, teacher for super specialty degree, FNB Reproductive Medicine, Delhi, practicing infertility for the last 25 years. Actually, it's more than 25 years. She is a director at 9 Bloom IVF centers. The first one is Lavati Hospital IVF Center, Mumbai, Bhatia Hospital Bloom IVF Center, Mumbai, Divya Patil Bloom IVF Fertility Center, Navi Mumbai, Fortis La Fime IVF Center, New Delhi, Fortis Bloom IVF Center, Chandigarh, Fortis Hiranandani IVF Center, Navi Mumbai, Babies and US IVF Center, Mumbai, Sakara Hospital, Bangalore, and Bloom IVF, Nashik. So, ma'am, over to you now.
Good afternoon, everybody. I think I would like to just say hello to everybody. I'm the president-elect in Hisar, and I'm really happy today to be talking on the topic. Can I have the next slide, please? Can I have the next slide? Okay, I think this is going to be really tough doing this, but let's see how efficiently we can do this. So today, I'm going to be talking about freeze all, is it an answer? And I think we all know that in the past decade, vitrification of the human embryo has become very, very good. And it has completely changed. In science or in life, there are some disruptions which cause major revolutions. And vitrification is one of the major disruptions in reproductive medicine, which has resulted in a lot of, positive changes, improved pregnancy rates, etc. And I think today's talk is going to be, let's go through all of it and see how it has helped us progress. Next slide, please. So if you look at vitrification, because of this technology, the embryo retrieval rate has reached 99%. Before, with slow freezing, only 50-40% embryos used to come back. The rest used to get damaged. But now with this technology, 99% embryo retrieval rate is there. So in my heart of hearts, while I'm still doing IVF, I hope our implantation rate also reaches 99%. Next slide. He's the man. I met him in America and he was such a simple person, very straightforward. Shapiro, his paper was the one which revolutionized everything. He came across and he said, freeze all. Because the pregnancy rates, his live birth rate, which he showed in that paper, was 70%. And I think that was the one which got everybody to think about it, to shift, etc. Next slide. So that's my topic today. Freeze all, is it the answer? If you look at, vitrification, I think today what I'm going to talk about is only an update on when to use it, what to use it, do we do it for all, what are the indications, etc., etc. Wow, my technical support guy is going to become an expert at freezing. The technology of freezing, I think we have to learn what are the benefits. What has freezing ultimately got us? So the embryo vitrification, the most significant benefit is improved survival rates. As I said, 99% of the embryos survive. Significantly improved cumulative pregnancy rates and improved safety of assisted reproduction. I think these are the three main pillars of vitrification. And also, we all know that multiple pregnancies gives high risk obstetrics. The world is moving towards single embryo transfer, and I think vitrification has played a major role, contributed a major role in getting us to do elective single embryo transfer. These three achievements have also been augmented by laboratory based developments like the silent revolution in embryo culture by blastocyst culture. We have to give credit to Gardner for this work. And the use of PGTA, I think the work done by Joyce Harper actually shows us that PGTA is something that can be used in a lot of patients and would be really helpful, especially in achieving single embryo transfer and achieving fantastic pregnancy rates. Can I have the next slide? So, what are slow freezings? Before 2006, we all used slow freezing. In fact, there are still centers, and one of my friends from Singapore is still using slow freezing, and he's mastered the technology. But what happened with slow freezing was there was an extracellular ice formation, and that what in that extracellular ice, the concentration of the cryoprotectants really increases, and therefore the final concentration of the cryoprotectant is actually higher, but it does not result in toxicity because it's at a very low temperature the cryoprotectant accumulates. However, the growth of extracellular ice is difficult to control, and therefore the egg and the embryo loss is higher because the ice can damage the embryo or the oocyte. And this is from a beautiful paper explained beautifully by Peter Zolt, in Fertility Sterility, Feb 2020. So what about vitrification? Vitrification employs a much higher starting concentration of cryoprotectants, but it's in a very micro dose and requires a very high rate of cooling. So because the cooling is like minus 25,000 degrees per minute, the micro volumes of cryo solutions are used. And for this, technical expertise is also very, very important. And adequate warming rates are important as cooling rates for good results. So this is a very important factor. It's skill based. Vitrification is skill based, and all the embryologists who are practicing it really need to, hone in their skills, do it more often so that they become experts. So when vitrification is performed correctly, ice crystal formation is eliminated in both the intracellular and extracellular spaces. And that is why the retrieval of the embryo is very good. In fact, vitrification is a revolution. In 2007, there were only 2,000 freeze-all cycles. But now the 2016 data shows 65,000 cycles. Can you imagine a 33 times increase in freezing? And all because this technology is really, really wonderful. Next slide, please. The live birth rates are also very, very important. If you see in 2001, the fresh ET live birth rate was higher than the frozen, because obviously you didn't want to keep good embryos for freezing because the embryo loss rate was very high, and also you put in 2233 embryos. But look at the 2016, the frozen thaw ET rates are definitely higher than the fresh ET rates, and that is what we have seen. So this meta-analysis in January 2019 was 8 RCDs and freeze-all strategy. If you compare it to hyper responders, definitely it showed a good pregnancy rate. Whereas with normal and poor responders, the live birth rate was the same. So what we need to understand is initially when Shapiro came with the publication, we all moved towards freeze-all. But this 2019 meta-analysis actually put us back into perspective that freeze-all is very good for hyper-responders, but it has not shown any better results in normal responders, and in poor responders, there are no studies. But here I beg to differ. I think in poor responders, freeze-all would be a good strategy because, we are using as the very high dosage of drugs, they have an effect on the endometrium. We know that. And also, if you do embryo pooling or egg pooling, then freeze-all is really the way to go. Can I have the next slide? So the indications of freeze-all, hyper-responders, GnRH analog trigger, OHSS, poor responders, fertility preservation, PGT, and the non-invasive chromosomal screening. So let's go through them one by one. OHSS, Devroy's famous paper about segmentation to prevent OHSS. I think that is what all of us are following. And we know that when you do a stimulation with an antagonist protocol and give a trigger with the agonist, you get embryos, you freeze them, and then transfer them in a frozen embryo transfer. You definitely reduce the OHSS. So simply being high risk for ovarian syndrome is also a setting. So I have a patient who is really lean thin, and she gave me just 4 or 5 eggs. But I still did freezing for her because this girl, even with 5 eggs, she went into hyperstimulation. So you have to be really vigilant about your patients and be more liberal with freeze-all rather than conservative. Next slide. So GnRH analog is another place where you use this as a trigger. So GnRH analog, when it's used as a trigger, what it does is, it blocks at the hypothalamic pituitary level, and the LH which is secreted is reduced, and that causes luteolysis. So when you use an agonist, it would really, really work well if you froze all your embryos. Or then, because the luteolysis would disrupt the luteal phase. Otherwise, you can use a fortified luteal phase, that is, give estrogen plus progesterone, or use low dose HCG as promoted by Humaydin, and we can actually achieve pregnancy by supporting the luteal phase. But generally, I would prefer not to transfer in a patient where I've used GnRH analog as a trigger. Now, poor ovarian reserve, as I've mentioned before, freeze-all strategy, I think, is indicated in poor ovarian response or extended stimulation. Duostim also, which we use double stimulation in one cycle, and which are shown to give really good results, more number of eggs, better pregnancy rates. Then elevated progesterone levels at the end of the ovarian stimulation phase, low oocyte or embryo number where you're doing pooling. And of course, I prefer to do it in endometriosis also. Because in endometriosis, what happens is, uh, there is a effect on the endometrium also. That is the inflammatory effect which we see in the endometrium, where the SIRT6 and the BCL6 enzymes, they are molecules which modify the endometrial response, and these are increased and they create more inflammation and less implantation. And that's why I think it's very, very important. And some have also suggested that it's better to avoid fresh transfer altogether when the embryos are transferred in the supraphysiologic environment found in fresh stimulation cycles, even in normal responders. Next slide, please. So fertility preservation is also one of the places where I do freeze all. I think, of course, it's very simple, it's straightforward, that the patient wants to preserve her fertility for the future. She does not want to have a child now, maybe due to cancer therapy, or maybe due to social reasons, or maybe due to hyperstimulation. I think freeze all would be the way to go in this particular patient. Next slide. Then PGT. I think pre-implantation genetic diagnosis for aneuploidy, for monogenic diseases, or structural breaks. So embryo biopsy is always nearly a reason to freeze all biopsied embryos. In fact, biopsies are performed on the blastocyst stage, and what we do is we freeze the blastocyst. In fact, sometimes in some places, even if fish is, PGTA is done and you get the report quickly, the success rate after a frozen embryo transfer is higher than after a fresh. So I think in all cases of PGD all over the world, all of us, even in our lab, we do a frozen embryo transfer. So we do the biopsy and we freeze all. Next slide. So when do we freeze? Which stage do we freeze at? So you can freeze it at the zygote stage, the cleavage stage, the modular stage, the blastocyst stage. So it allows high rates of viability, whichever stage you freeze it for. But what is popular is day 3 and day 5 transfers is something that we are looking at always, and we freeze those in our laboratories. Next slide. Now, expanded blastocyst is something that you must remember, that you need to cause shrinkage of the blastocyst cavity, because when the fluid is too much in the blastocyst, the vitrification fluid does not percolate, and it does not, like protect the embryo. So that's why artificial shrinkage is important. What we normally use in the lab is a laser, and this causes the disruption of the intercellular connections in the trophectoderm, which results in the shrinkage of the blastocyst. And this is especially beneficial when cryopreserving expanded blastocysts and may improve embryo viability and implantation potential. And remember, when you thaw this blastocyst, wait for it to expand and then do the transfer. So typically on thawing, remember that you must wait for 1 to 2 hours, because what happens is all the cryoprotectant is then taken out of the embryo. It seeps out of the embryo. So it's very important to have that period between thawing and embryo transfer. Then what about repeated warming, vitrification, or repeated biopsy procedure? I think this is a practical question which all of us have. That if you have an embryo and you've not used it and you want to re-vitrify it, friends, nothing happens. All the studies so far have shown that it's absolutely safe. There's no problem. In fact, in our unit, we use banked eggs. We use the eggs, we inject them, create embryos, and then again freeze the embryos. So we've had no problems whatsoever. The viability is same, the pregnancy rate is same. Only remember, occasionally, when you have biopsied the embryo twice, that does reduce the potential implantation potential, the viability potential of that embryo. So multiple biopsies is not advocated, but you can do multiple vitrification to the same embryo. Next slide, please. This is a very important part, especially now in the COVID era, the cryo storage and the monitoring, because we all use cryo cans and the liquid nitrogen evaporates, and we need to keep our, biological gametes, embryos in the liquid nitrogen to maintain the temperature. So all of us during COVID have been seeing that liquid nitrogen supply is uninterrupted, and we go in and we, fill it up so that the gametes are kept at the uniform temperature. So it's very, very important for storage and monitoring. Next slide. I think just wanted to show you, this is Dana Hayden, Miss World, and those are her 3 babies, 2 daughters, 1 boy, born from cryopreserved eggs and embryos. So I think it's a standing example, and this is of course Ekta Kapoor, who froze her eggs at 34 years age, and then 7 years later she had this baby. I think vitrification has really, really changed everything. And the number of years of vitrification also don't matter. As you can see in both these patients, the eggs and the embryos were kept for more than 5 years. Next slide. So cryo storage and monitoring, what is the fear that we always have? Cross-contamination. But numerous studies have shown that cross-contamination is really not possible. It's very, very difficult. And with the new closed systems, it's definitely not possible. But yes, if you want to avoid cross-contamination, you can even store the gametes in the liquid nitrogen vapor, so that you're not immerse them in the liquid. But we've been using it for since 2006, and we've had no problems with cross contamination. Accidental warming is something that you must be careful about. Improper handling from vitrification vat to storage tank. when you're transferring the embryos, you vitrified them and you put it into the storage tank. You have to be very, very careful that they are kept under liquid nitrogen all the time. And the movement of the samples in and out of the tank is also very important. And failure of seal and maintaining vacuum, these are some of the things that can cause problems. So a good system ideally would be the one which would tell me before, that your storage tank is in trouble. Please take precautions, which is still not available with us. But yeah, maybe something that can, is weighing that liquid nitrogen can. And if the weight reduces because the liquid nitrogen evaporates out, that should ring a bell or something. And or even if it's leaking out, kind of a thermal sensor outside the can. Now these things can probably help us, but till they come, we have to be very vigilant and we have to watch that everything is maintained properly. Next slide. Uh, the outcomes are very, very important. And I think any technology in IVF, unfortunately, the technologies really make an entry fast into a clinical scenario. So the outcomes, there was this Danish study which really scared me also, that the childhood cancer incidence increases. But when I read the full article and I really came across these things, I think everybody should be aware that the relative risk is more, but the absolute risk is extremely low. And the study design was not good, extreme differences in group sizes, extreme low prevalence of disease finding, possible type 1 error, and most of these cases in the Danish study were slow freezing. So probably they don't even apply to the vitrification. But I think this needs to be really re-evaluated in a different way. Now, the endometrial preparation is very, very important. What's the time? Okay, 3:20, not bad. Okay, the endometrial preparation is very, very important for frozen toy ET. Like you can have a program cycle, which most of us do, because it's easy, it's convenient. We give estrogen, progesterone, and we can time the ET according to when I'm available and all. But the best results have been shown with the natural cycle and modified natural cycle. Modified natural cycle will be more of a way to go because you can definitely time it and it gives you good results. And of course, there are certain cases where we do stimulated cycles. Now, remember, when you do program cycles, about 15 to 20% of your cycles will not develop. And you will have to do a modified natural cycle or a stimulated cycle for it. And in fact, modified natural cycle, the chance of cycle cancellation is much, much lower. So when you prepare a patient, if it's a HRT cycle, that is an artificial cycle for FET, then the endometrial thickness should be at least 7 mm or more. And this is a study of 20,000 plus FETs, and 7 mm and more gives good results. And when it's a modified, go back, please. When if it's a modified natural cycle, then the endometrial thickness should be 8 mm, more than 8 mm. And every mm that is lesser, like say 6 mm, 5 mm, the pregnancy rate keeps dropping. Now, can we go to the next? As I said before, inflammation is a prime candidate for progesterone resistance. And inflammatory milieu, there's increase in cyclooxygenase, which causes increased endometrial aromatase expression, which increases estrogen activity, as well as the SIRT1 and BCL3, which I told you, which are molecular mediators of progesterone resistance. So endometrium shifts to a more estrogen receptor positive state, then it would have an anti-implantation effect. So endometrium, increased estrogen activity, estrogen receptor positive, and anti-implantation. So that is what causes progesterone resistance. So how can we treat it? We can increase the estrogen to progesterone ratio and benefit our patients. Then if it's endometriosis, which is causing this, I would give GnRH analog to reduce the inflammatory changes. Next slide, please. And if there's infection, treat the infection. Then ERA is another test, 238 genes involved. It's been there for a long time, window of implantation. But the studies in 2018 and 2019 suggested that doing an ERA did not make any difference in your pregnancy rates. Next slide. But what it did show was that supposing there was a woman who had a euploid, tested normal embryo, and it was put in a ERA tested endometrium, that perfectly window of implantation and all, and it doesn't implant, that means there has to be some other reason for recurrent implantation failure. So the negative connotation is more important because then you will have to look for other causes. Next slide, please. Now, when we are talking about blastocyst transfer and everything, this compaction studies in 2019 were really interesting, and a lot more is now coming out, saying that if by day 5 your endometrial thickness should undergo compaction, and this particular study showed that only one third of the endometriums undergo compaction. So that is why we need to look at it. Okay, what is the problem with the endometrium? Is there progesterone resistance? Is there an inflammation? Or is there infection? And treat that accordingly. And if the more the endometrium compacted, the better are the pregnancy rates. Next slide. Of course, the obstetric outcomes are also different, and this is something really very recent which I came across in the journal, and I will let you know about it. So, if you look at this meta-analysis of frozen embryo transfer, 31 studies were in it, and you can see that FET was associated with lower risk of placenta previa, placental disruption, and a low birth weight as compared with fresh ET. But what were the problems that increased? Pregnancy induced hypertension, postpartum hemorrhage, and a large for gestational age baby. So it has its pros and it has its cons. Can I have the next slide? And this was a very interesting study, Nordic study, because the patients were their own controls. The same patient was her own control. And it was shown that with the FET, the incidence of PIH was definitely higher. And in another study by Kirk Conrad, he proposed the hypothesis that the absence of corpus luteum in the program cycles is probably why there is an increased risk of PIH in these patients. And let's look at the next study to explain why. Next slide, please. So in Feb 2020, Buchitra Singh has written a lovely article that what does a corpus luteum do? Corpus luteum not only secretes progesterone and estrogen, but a lot of vasoactive substances also, like relaxin, VEGF, angiogenic metabolites of the estrogen. And all these are the ones which prevent preeclampsia. So, because in a program cycle you don't have all these other products of corpus luteum, it's probably seen that in FET with program cycles there's a higher incidence. Next slide, please. So this is again a 2019 human reproduction study where there were natural cycles were 29,000 and program cycles were 75,000. Because the number was very high, I wanted to bring it to you that there were increased odds of hypertensive disorders of pregnancy and placenta accreta in programmed FETs, and decreased odds for gestational diabetes in programmed ETs. The pregnancy and live birth rates were significantly lower in the programmed versus natural conception cycles. So I think maybe it's time we start thinking about it and changing our practice. And I'd like to conclude my talk by saying, yes, freeze-all has its advantages. It facilitates a single embryo transfer, reduces risk of OHSS, it allows time for PGT, and it gives us flexibility in scheduling. whereas the disadvantages are higher risks of high PIH in the pregnancy, increases the time to pregnancy, and allows time for PGT is of course a positive. Can I have the next slide? Now, I want to talk a little bit about freezing during COVID. There are a lot of questions which I get asked on various seminars. Now, you have to remember that COVID virus is very, very infective. As you can see in my first part of the chart, that for every one COVID patient, 2 to 3 patients will get infected. And we all know attacks. If you see on the right the lines of attack, it always usually acts through the ACE inhibitors. Now, in IVF or in fertility, when we consider the ACE receptors are present in the testes, they're present in on the embryo, and they're present in the ovary. So there is every chance that it can get infected. There is a latest study about the semen which shows that 15% of the semen out of the 50 patients that were checked, 37 could give the sample, and out of that 15% showed the RNA positive of the COVID virus. So the only problem is the RNA can be infective. We don't know. So at the moment, we are not very sure whether it's infective or not. And that is why you should have separate freezers during the COVID era. The second is that there are follicular fluid, no studies have been done, so we don't know whether the oocytes contain the COVID virus or not. So again, freezing during this period should definitely be done separately. And the embryos contain the ACE inhibitors, and that's why. But remember one thing: with all our material that which we use, sperm, eggs, embryos, if we wash them repeatedly, the virus gets washed away, and the chances of infection are very, very poor. And the dilution washes that we give the embryo and the egg when we thaw them, I think that would be great. So ideally in this situation, it's better to triage your patients, put them in a category where COVID positive, COVID negative, and keep separate containers. But also I feel as a precaution, now once we start our clinics, we should have a separate container for cryopreserving even COVID negative patients, because the tests are only 70% accurate, and there could be asymptomatic patients or patients in the window period which we've missed. So it would be a good practice recommendation to have a separate container during the COVID times. And COVID positive patients, all the organizations the world over, and we are coming up with guidelines, and they are also saying that COVID positive patients, you should not do IVF at all in those patients. So thank you. I think I have finished my talk, and if there are any questions, I would love to answer them. I'm sorry, I forgot your name.
Tejas, it's Tejas.
Tejas.
Yeah.
Thank you, Tejas. I think now we can answer questions.
Yes, ma'am. Sure.
Tejas has become an IVF expert, no, Tejas?
Yeah. So there are few questions. Hello, ma'am. Hello, ma'am. Able to hear me? Hello.
Yeah, Tejas, I think I had gone offline.
Yes, ma'am.
Okay.
Okay, so ma'am, there are a few questions coming in.
Yeah.
So there's one question from Dr. Dheeraj from Chennai.
Baru.
Yeah.
Okay.
So he's asking, ma'am, for all patients who took agonist trigger, should we
Yeah.
go for frozen embryo transfer, or can we do it, or can we fresh ET as well?
See, in my practice, Dheeraj, I personally do frozen embryo transfer for all GnRH agonist trigger. But yes, you can do a fresh transfer. But see, now it depends on what reason you're giving the GnRH agonist trigger. If it's for hyperstimulation, you have to weigh the pros and cons. That if you get a pregnant, will she go into secondary hyperstimulation? So that way, if you've given it just to get good eggs, we give a dual stim or GnRH analog, even in poor responders, then you could transfer but use HCG as a backup in the luteal phase. So what you can do is you can give HCG 1500 units on the day of the pickup and then 4 days later. That is one protocol. Or you can give 100 units of HCG every day from the day of the pickup. That is the second protocol. And the third protocol is estrogens, 2 milligrams BID or TID, and progesterone, 200 milligrams TID vaginally, or 10 milligrams 2BD oral dihydrogesterone, or that's it.
Okay, so the next question is coming from Dr. Sutha Joshi Prakash. She's
Yeah.
asking, how long will you wait for endometrium tubule
Oh,
at the most, madam?
question. That's a good question. I would not, if it took more than 28 days of estrogen, I would not continue that cycle. I would drop that cycle. So 28 days is maximum that I would do in a program cycle. Next
Okay,
question.
so the next question is coming from Dr. Shri Harsha from Guntur. She's asking, how many days of progesterone do you give before day 3 and day 5 transfer? Is it minus 3 and 5 or 2 and 4?
I think I start from day zero. Day zero, day one, day two, and day three, I do the transfer. So, day zero, my day of the pickup is when I start the progesterone. So, if for a cleavage stage, it will be day zero, day one, day two, and day three, I would transfer. That means on fourth day of progesterone. And if it is a blastocyst, it would be the sixth day of progesterone.
Okay, so the next question is coming from Dr. Anuj. He's asking, can you explain as how you will diagnose progesterone resistance?
Very difficult. It is absolutely difficult to do that. So what we know that the pregnancy rates in endometriosis patients is low. Supposing even and I would also in hysteroscopy, if I see signs of endometritis, chronic endometritis, I would give antibiotics. So these are the two indirect ways of finding out progesterone resistance. And there is something called progesterone receptor resistance also. But of course, that's a very molecular level test, which we don't do. But you could try giving high doses of progesterone. You could try giving GnRH analog. And the third one is antibiotics.
Yeah, so Dr. Shalini from Mumbai, she's asking, can you explain about the ovarian reserve in poor responders and how can it help in managing it?
Oh, I love this topic. I have got 40 plus women also pregnant with their own eggs. In fact, I delivered four of them this January and February. So, what we do is, first of all, I am a firm believer of DHEA, testosterone gel. So, these are the things which I like to give for long term. Give it for 6 weeks, 8 weeks, 10 weeks, 20 weeks, whatever. Give it till you do keep collecting eggs. So, what we do is we use the high dose protocol first. Gonadotropins 450. Uh, Either you can use recombinant FSH plus recombinant LH combination, or you can use HMG combination, and you do the pickup. And then on the day of the pickup, we don't do eggs which are less than 12 millimeters and lesser. So then after 4 days, again, I can start the stimulation straight away for the next duostim. That is one way. Or the other way is we do this if patient responds with only one or two eggs, then I go to minimal stimulation in the next cycle. So these are the ways in which you can do poor ovarian reserve, and we've got good results. Even AMH 0.7, 0.4, we've collected oocytes and got the patients pregnant.
Yes. So the next question is from Dr. Palchen from Mumbai. He's asking what percentage of frozen embryos survive in the thaw?
100%.
That was crisp. So Mr. Bhavesh from Delhi, he's asking composition of the cryoprotectants used.
I don't know all that. I mean, I used to, I know it when it's in front of me, but it's all, these are all ready-made components here. They are all done properly and mixed and everything. So I wouldn't be able to tell you that. It's all on the web.
Okay. So the next question is again from Dr. Sudha Joshi Prakash from Chennai. She's asking when will you use GnRH agonist primed HRT cycle?
Oh, sometimes what happens is when you're using estrogen plus progesterone, a follicle just grows. It does not get suppressed. So, in those cases, in the next cycle, I would use a GnRH analog suppression. Then, all cases of endometriosis, adenomyosis, I would use GnRH. In fact, maybe even 2 months prior to doing a FET.
Okay.
And
So
also, sorry, and also PCOS patients, because I feel in PCOS there's hyperplasia of the endometrium. So giving GnRH analog before doing FET is really good.
okay, so Dr. Hamida from Mumbai, she's asking for research purpose, how much minimum time should we keep sperm to vitrify in order to check any effect induced during the process?
Uh, first of all, we don't do sperm vitrification. So I'm sorry, I can't answer that question.
Okay. So the next question is from Dr. Mahi Jha from Bangalore.
Yeah.
She's asking, can you share your experience about cryotop vitrification of embryos?
Yeah, we use cryotop only and we are very, very happy with it. Totally happy with it. But again, it's a technically, it's a skilled process and your embryologist has to be an expert. It's very good.
Okay, so the next
That is a
question.
carrier. Yeah.
So Dr. Dheeraj Yala from Vizianagaram is asking, I see slow freezing being done in some IVF centers even in the era of vitrification. What are the
Yes.
advantages of slow freezing?
See, slow freezing has been there for a long time. And besides that Danish study, there are no studies which actually say that it harms the children or anything. And, people have been born and survived for 30 years after slow freezing. So that long-term advantage is there in slow freezing. But otherwise, I know that a few people are doing. In fact, when I went to Denmark for my ovarian tissue freezing, I learned the ovarian tissue freezing as in the slow freezing. And still, there are now people have switched to vitrification for the ovarian tissue. But most of the babies that are born out of ovarian tissue freezing are slow freezing babies. So it's been there for a long time. We know much about it. So this is a new technology, and it has actually jumped into clinical practice without much animal studies, I feel.
Okay, so Dr. Sri Harsha is again asking one more question. She's
Yeah,
asking natural cycle FET. Can you
yeah.
elaborate on monitoring protocol?
Oh, I don't do it, but I'll tell you about it. Natural cycle meaning you do a day two scan, and natural cycle actually you can do a E2, P2 level, P4 level also, and then watch the follicle grow. Once the follicle is about 16, 17 you need to call off a sonography daily because you need to watch for rupture. Once it ruptures, that is the day you start your progesterone and do the transfer accordingly. As I said, 4 days for day three transfer and 6 days for a blastocyst transfer.
Okay, so the next question is coming from Dr. Padma Shri from Coimbatore. She's
Yeah.
asking, what is the ideal estrogen to progesterone ratio in FET cycle?
There's no ideal or anything. We normally, I don't like to increase beyond 10 milligrams per day. But of course, that's one more thing that I want to tell everybody, that increasing the estrogen does not help us in increasing the endometrial thickness. So I think we should stick to 6 to 8 milligrams of estrogen and add other things like, anti-inflammatories, treat the infection, etc.
Okay, so Dr. Aparna from Mumbai, she's asking, can you explain the order of thawing?
I'm not an embryologist, so I can't explain the process. And usually I do learn it before a talk or before I talk in a workshop, but today definitely not. I mean, I don't go into the lab. So
Okay,
sorry, maybe you can ask an embryologist in my unit.
yes. So Dr. Bhargava from Haryana, he's asking, is there a potential of abnormalities while doing the same? Like what?
Is there a what? I didn't get the question. Sorry.
Mm, he's only asked, is there a potential of abnormalities while doing the same? Like
Potential
what?
of abnormalities. Okay. See, the incidence of abnormalities is the same with IVF, frozen, fresh, etc. There's no increase in congenital anomaly rates or teratogenic effects due to vitrification. So that's how we know that it is safe.
Okay, so again, Dr. Sutha from Chennai, she's asking, how do you carry over minimal stimulation?
How, acha, the minimal stimulation. Minimal stimulation is simple. I use clomiphene citrate from day 2 to day 6, 100 milligrams per day. And day 7, actually, day 6, I start giving gonadotropins, maybe 300 international units every day. And the antagonist is added as and when the follicle turns 13, 14 millimeters and above.
Okay, so this is the last one from Dr. Dheeraj. He's asking, ma'am, any role of vocal study of endometrial volume for deciding to go ahead for FET or not? If so, how much the volume should be?
No, there have been studies on the volume and all. Unfortunately, I'm not that interested uh, in sonography, so I have stuck to endometrial thickness and all. But there are especially when people do lateral metroplasties, etc., to increase the volume of the cavity. I think that is where this probably would hold true. So I am not sure of the numbers, but normal uterus is about 7 by 5 by 2. So anything less than that would probably result in a lower volume. I am really not aware of volume studies. Sorry.
Ma'am, that's all with the questions now. I'll just request you for a short takeaway message for the doctors.
Yeah, first of all, I want to thank ISAR, congratulate Dr. Prakash Trivedi and Dr. Kedar Ganla. And I'm happy to be with Doc Mode. I've done a lot of programs with Doc Mode. I think y'all are very good. And I'm very impressed that a non medico conducting the whole session, asking questions, moderating is really wonderful. So, Tejas, full marks to you
Yeah,
for
thank you,
doing
ma'am.
a great thing. And friends, what I would like to give my parting shot is that cryopreservation is here to stay. And so is COVID here to stay for another 6 months to 1 year. So we need to take precautions. I know it is extra expenditure in getting a new cryo can, keeping it separate. But I think if possible, we should do it for the safety of ourselves as well as our patients. So master cryopreservation because it is something that you cannot practice IVF without. And it gives fantastic results. And I just, 2006 changed my life. Let me tell you, I had one patient who came to me in 2006, straight after Diwali, November. She was abroad and she came down and she did a pickup and we got 12 embryos. She was a famous girl, 12 embryos. I put in three and she conceived. Okay. And Diana Hayden, whom I'm talking about, came in December and her eggs were vitrified. And she gave us lots of eggs. The first patient who came to me in November, in the slow freezing era, she wanted to do a second ET. None of her embryos survived. I think out of 12 embryos, we got back only 3 embryos which were viable and which gave us a baby. So I think we must remember that vitrification has changed. And look at Diana, she's got 3 children. This girl has got only 1 children out of the same number of eggs, same age, same type of ovarian reserve. So I think vitrification is here to change our lives, and the faster we master it, the better it is. So that's all. Thank you, and really enjoyed the question answers. And I will look up the study about volume, definitely. And vitrification of sperm, I think you should ask some embryologist. Thank you, Tejas.